Yes.
Thank you, thank you. Well, thank you for having me today. I think some fantastic topics that we have for you. As part of the structure on program sort of offerings, I'm going to talk about one area in particular, but like Dr. Menina was alluding to, our program encompasses uh, uh, all of the facets that deal with sort of minimally invasive therapies with respect to heart valve disease or shunts in the heart. And this is one other such area that I'm going to talk a little bit more about today, because this is something that we really see very commonly in the community, and trying to figure out the best way to one, identify those types of patients and to get them in for evaluation, I think is important. So to that end, I wanted to speak to the group today a little bit about left atrial appendage occlusion, and in particular the Watchman device developed by Boston Scientific, and also talk a little bit about ways in which we can help improve referral flow for those patients that you see. To the left of the screen, you'll see a QR code that you can utilize your phone to really download a mobile app onto your device that would allow you to get in touch with any of us on the cardiology side. And if there's patients or questions that you do have, at least there's a great way or a resource that you have available to you to help get your questions answered or your patients seen. And the invite code down there below is case sensitive. So as far as atrial fibrillation is concerned, it is a very common problem. It's the most common heart rhythm abnormality in folks over the age of 65. That population of AFibs is expected to essentially double by 2030. And about 20% of our strokes, or all strokes across the country, are AF related. And with more than half of these people who do have a stroke will again experience another stroke within 6 months after the initial event. So clearly a huge concern, both from a morbidity and mortality perspective. But interestingly enough, as it pertains to atrial fibrillation, about 90% of the strokes that go on to cause 90% of the strokes that do occur in those individuals with atrial fibrillation occur in the left atrial appendage. Now, the left atrial appendage is a vestigial sac, kind of what I would consider the beginnings of the heart. And after you're born, it starts to have diminishing value. And for those folks on the call, the appendage is really not a muscular structure. It's basically tissue, and so its emptying of that appendage is contingent upon the left atrium contracting. And when we go into atrial fibrillation, that lack of contractility just causes the blood to stagnate inside the appendage and then potentially clot, which is the main reason why anticoagulation is recommended. And with this, right, there's a lot on this slide, but basically, significant morbidity associated with AF related strokes compared to non-AF related strokes in particular. But the folks getting back to their regular way of life is significantly diminished after a stroke secondary to atrial fibrillation. So something that we really need to address. And in looking at, well, how do we address this from a stroke prophylaxis point of view? There were some newly published guidelines a couple of years ago, and really looking at which patients do we really need to look at, which patients should we consider anticoagulation on for the purposes of stroke risk reduction. And really the CHADS-VASc score, or the CHAD score, is utilized to help determine which patients need to be on anticoagulation. And suffice it to say that men with a CHADS-VASc of 2 or greater, or females with a CHADS-VASc of 3 or greater, should strongly be considered for anticoagulation. And if you look at folks who have a CHADS-VASc score lower than that, we start to see, do we just give aspirin only as a method for stroke prophylaxis? But even if you look at anticoagulation, and in particular warfarin, and understand, well, what percent of patients are actually within the therapeutic range, you can see that the vast majority, about 8% of patients are saying, are essentially spend time or consistently spend time within the therapeutic range, with a significant number of patients remaining either below or above therapeutic levels, which obviously have risks one way or the other. Obviously, if you're over anticoagulated, the risk for bleeding is high, and if you're under anticoagulated, you've not really helped reduce your risk for stroke very much. And so if we look at this, and you say, well, gosh, I mean, how many folks who who need to be on anticoagulation are actually not? And really, about half of the people really who need to be on AC are actually on it, and of course the other half are not. And on top of that, if you look at the folks who are taking anticoagulation, it doesn't end up being a long-term medication for several different reasons. But about 30% of the folks taking a direct oral anticoagulant like Eliquis or Pradaxa or Xarelto, or half the folks taking warfarin, really stop treatment after 2 years, and at a significant percentage. And then if you look at the folks who do remain on a DOAC, given that, gosh, it's easy, you just take it once or twice a day, there's no monitoring that's needed, even then a significant percentage of patients really remain non-adherent to therapy. And so that poses a significant concern with respect to stroke risk. And we see it very frequently in our offices, and unfortunately in the hospital when folks do come in with stroke-like symptoms. So Watchman has really been a game changer in terms of what we are able to offer patients. It was started up in clinical trials in 2002, finally finished up with FDA, or sort of it finished up with its clinical trials in 2014, was FDA approved in 15 and approved by CMS in 16, and that's when we started implanting. But it is a minimally invasive procedure. It is considered a permanent implant. Many patients ask, do we take it out after a while? And that's not the case. Once we put it in there, it heals in there, and I'll show you in the bottom pictures how. We keep most folks overnight in the hospital, and it takes us about an hour to implant. But really, and this is a big sort of blow up version of this device. But what I wanted to point out was that there's a white sort of fabric over top of the device, and those the pore sizes, there's very, very small pores, but the pore size in there is about 160 microns in diameter. But suffice it to say that it's very difficult for thrombus that does form to actually get through the Watchman device once it's present. And you'll see these little barbs that circumvent the device. There's two little, like J hooks, if you will, look like fishing hooks. And there's a total of 18 of those hooks that circumvent the device and really allow it to lodge into the left atrial appendage tissue. On the bottom panel there, we're able to go through the femoral vein. We are just in a very routine fashion able to cross the piece of tissue that separates the right and the left atrium. We place a catheter in the appendage there and essentially unsheath the device, which sits inside the delivery sheath. And what ends up happening over time is that tissue essentially grows over the face of the device. So how I describe it to my patients is like fixing a hole in sheetrock, where the Watchman device essentially is that sort of impermeable mesh over which we can put our sheetrock and mud, and they seem to understand that very well. But this allows essentially for an almost 90% reduction, if you will, risk in stroke just by having that appendage occluded. And many patients, what we found after being able to stop their anticoagulation, sure, they do and are very happy with the fact that they no longer have to pay all this money per month. They're not worried about having, if they do fall, what problems they may have as a result of that. But looking at the reduction in stroke and bleeding death has been well shown in the clinical trials, and even in the smaller studies. The death benefit that patients do receive from having a Watchman device placed are those individuals in which you've had a prior subdural bleed or intracranial bleed, and then are implanted with this device after their 6 to 8 weeks of recovery and clearance by neurosurgery. And those are the folks in which we're able to prevent a second intracranial bleed, are the ones who this device has helped the most and offered that sort of death benefit as pertains to Watchman implantation. Now, many of the folks that do undergo Watchman implantation, a significant percentage do come off of anticoagulation at 45 days and most at 1 year. This data is based on the older generation Watchman device, which what I call the 2.5. What we're utilizing now is the Watchman Flex device, which is what I kind of showed you a few slides back. And those rates of anticoagulation discontinuation are a little bit higher at the 45-day mark. I think it's around 95% at 45 days. And the nice thing, after the 45 days, what do they receive? And generally speaking, at 45 days, the device is not completely endothelialized. So what we do recommend is a short duration of a baby aspirin and Plavix that they would take for about 4.5 months. And after the 4.5 months, we just discontinue the Plavix. And so their anticoagulation regimen at the 6-month mark after device implantation is essentially a baby aspirin. And a baby aspirin plus this device is just as effective as being on either warfarin or a DOAC in terms of stroke risk reduction, except not having the untoward risks as a result of anticoagulation. So a very effective therapy. And on top of that, even if we look at cost, cost obviously is a big issue. And in many cases, cost is an impediment in our Medicare patients of remaining on these newer generation anticoagulants. And in many cases, they're either splitting doses, taking single doses, or not taking the medications at all, which of course poses a significant risk. But if we just compare the Watchman device to warfarin, even at 2 years, the Watchman is slightly lower cost than warfarin, just based on pro time checks, because those are some of these visits do cost money, of course. But then if you look at 5 years out, Watchman is shown to be significantly less expensive than warfarin. If I were to compare that and overlay it with DOACs, you would find that you would reach those time points much sooner, given the expense of the medication itself. So who is a great patient for Watchman? Well, there are specifics that we have to look at in terms of which patients would benefit. And essentially, their CHADS-VASc score has to be 3 or greater, or their CHADS-2 has to be 2 or greater. And it doesn't need to be a cardiologist that says, hey, look, this patient would benefit from Watchman implantation. That is not the case. In actuality, there are about 40% of patients out there who are actually managed by primary care alone. And in many instances, I think there are opportunities to co-manage these patients. But if we're seeing patients that are coming into the office, who would be seemingly not a good candidate for anticoagulation, anybody can essentially refer on for an additional evaluation for Watchman consideration. But really, it's not those who just bleed. I mean, that's the obvious. We need to look at different reasons for why patients would not be great long-term candidates for anticoagulation. And whether it be from other medical conditions causing like thrombocytopenia, if they've got if they, for example, have had stents, and they need to be on dual antiplatelet therapy, and there's some concern with respect to maintaining that degree of anticoagulation, I think those would be candidates. Folks who've had a history of falls, those folks who have a documented issue with just poor compliance with respect to oral anticoagulants, those individual candidates are as well. Those folks who we have a hard time maintaining in the therapeutic range for INR is also a reasonable option. Occupations, lifestyles, bad kidneys. There are other areas or other reasons why patients would not be good candidates. We had placed a Watchman device in a police officer and in a martial arts instructor, mainly because of the trauma related to their occupations and or their jobs, and trying to figure out how we can reduce their risk for untoward events. So it's more than just for those folks who've had bleeds. And people coming into the office, let's say your patient's coming in, rolling in with a walker. I mean, the reason they have a walker is because they're unstable on their feet, and those are candidates for Watchman consideration as well. So this is just our Watchman device going in. You can see it essentially plugs off that left atrial appendage, and the right screen there shows just kind of what it looks like with our three-dimensional imaging technology that we have with transesophageal echoes. But essentially, these folks that are on the right, the 4 patients that are listed as examples, I mean, are all great candidates. It's not the folks who are just old and frail that we should either consider for this therapy. As long as there's a reasonable indication for something like this, I think it ought to be considered. There are actually clinical trials going on right now looking at whether patients who come in with new onset atrial fibrillation are they better candidates for Watchman right up front versus continued oral anticoagulation. That trial is going on right now. So the question is how to refer. And I think one of the applications that we're using, especially for physicians who are outside of WellStar, is an application called Loop. And really, it was developed out of a need, given just the subspecialization within the specialties, and understanding how we can get to that right person for an evaluation. I think one of the problems that we have found is that if we're able to improve the patient experience by limiting the number of visits for them to get to the right physician, that's helpful to the patient and their family. At the same time, and as was brought up previously during this discussion, I think awareness is key. And how do we provide that type of communication in a timely manner to the medical community? And I think that's one of the areas that this application does solve for as well. Finding the right provider the first time around is critical, I think, to improving patient compliance and the experience. And really, at the end, one other facet with this is it's a communication tool to keep both the referring and the consulting care teams in the loop of what's going on with their patient. So this is kind of my screen, actually. And when you open up the app, this is kind of what you see. It's kind of like just a feed of what's going on within the practice. And that's something that we utilize internally to let members of our own group know what's going on. We can play pictures and videos and do all that fun stuff that you'd see with any typical application. Clicking the home screen will take you to a various menu. In here I can search for things, and one of the things I can search for is Watchman. And when I click on it, I can learn more about the information about the device. I can click on a web link that'll take me to Boston's website, and then when I click next, it takes me to a list of physicians that are really arranged in order of geography relative to my clinic. I can click on a name, the reason for referring, and then essentially entering in patient information will allow me to kind of send that referral on to Dr. Patel and his staff. And then from there, the staff really will work on getting the patient in for evaluation. So a really interesting way. There's multiple tutorials throughout the application as well that will guide the user through it. And I'll have Joanne and Mara send out this in a separate link afterwards for those individuals interested in downloading the application and learning more. But I wanted to thank you for your time. If there's any questions, I'd be happy to answer them.
This is Harvey Sachs. Dr. Mangal had another commitment. So are there any other questions for Dr. Patel? This was a great presentation, Amar, and everyone really enjoyed it. Did anyone else have any questions?
I see a question. This is Dr. Howard. I see a question from on the chat. What is the total cost of the Watchman deployment?
Oh, great question. So it is covered by insurance, and we've had some difficulties with Blue Cross, but Medicare, it's all of it is covered through, and all of it's pre-certed as well. So if there's any insurance issues, Boston Scientific actually is working with us to ensure that if there is an indication that we're actually presenting it appropriately to the insurance company, to provide them with the rationale of why this device is being or should be considered over long-term anticoagulation. But all of it's run through insurance beforehand.
Did anyone else have any questions?
I think I have one. Great job, Dr. Patel. You know, I know that we're doing more and more Watchmans these days, and I remember the Lariat device. Is that device gone now? Is it fallen out of favor? I know it's more technically challenging. What's the latest on that?
Oh, great. So the Lariat device, for those that you don't know, it was like a lasso device that was developed by a cardiac surgeon out in Texas. And we were implanting those devices years back prior to Watchman. And like Dr. Howard was saying, it's essentially a device that we kind of lasso around the appendage, essentially tie the appendage off. And the way that got FDA approved was through one of those 510 approvals, and for soft tissue closure. However, it never really proved itself to reduce the risk for stroke because it didn't have any of that data. Watchman is the only device that's been shown to reduce the risk for stroke. So whether it's a lasso, whether it's even there's a clip device that we can also put in through a left thoracotomy, those devices have yet to show a trial that says yes, this actually reduces the risk for stroke, even though it's assumed that if you're closing off the appendage, that your risk should go down regardless of the mechanism. But there was a letter that came up by the FDA years ago stipulating that those findings, and at that time Watchman was now commercially approved. So we did switch gears and went with a commercially approved therapy with great data.
Omar, sorry, one last question. So we all have these patients that have AFib, they're at risk, usually a younger patient. They have no real contraindications to anticoagulation, no label INRs, they just refuse to take it. Is there a pathway for these patients to get a Watchman if just based on their refusal or for patient preference to have a device as opposed to long-term anticoagulation?
Great, Sal. It's a great question. And Sal just described the only indication, the only reason for which Watchman is currently not approved for. And that really is just patients who don't want to take anticoagulation. They don't be bothered with it. Now, if there's a reason behind it that makes sense, you know, outside of this, that they don't want to do it. I mean, we obviously want to listen to that and understand what their concerns are. There is a trial that's ongoing, but half of those patients would be randomized to oral anticoagulants and the other half to the Watchman device. There's a 50% chance that they might get it, but short of that, there's no other way. And on top of that, I'm not sure how insurance covers it for those individuals in the trial. So it's a very challenging prospect at this time for a straight up patient refusal.
Yeah, it would be interesting for the insurance to do a cost analysis because when you look at the long-term cost of anticoagulation versus a one-time cost of the device, I would surmise that it's probably beneficial financially to put in a device as opposed to having a 50-year-old take anticoagulation for 40 years.
You know, the main reason why they don't do that is because they know the number of years the patient stays on their insurance plan doesn't pan out. If you have a patient that stays on a single insurance plan for like 5 years, it makes all the sense in the world. But since how people like will change from Humana to Blue Cross to United, depending on who their insurer is or whatever, that's what's driving these insurance companies to say, hey, look, we're not sure it's cost effective for us.
Okay, well, thank you again. If there's no further questions, I will turn this over to Dr. Howard for the last presentation.
I think Dr. Zhu had a question.
Oh, sorry.
Oh, for a failed Watchman. So when we look at failed Watchmen, and you look at and I didn't go into complications, the complication rate for the Watchman Flex device is 0.5%. And all 0.5% was related to one thing, and that was effusions or pericardial effusions during the procedure. And you know, the appendage tissue thickness, depending on the appendage, varies between 1 to 2 millimeters in thickness. So it's not that thick. And you know, if there's any trauma to the area, that it can result in a pericardial effusion. So we're very careful about deploying that device. But at the same time, there's criteria that are present that let us know that this device cannot sit here safely. And in those cases, we actually take the Watchman device out prior to its last deployment step. So there are fail-safes that we do have to prevent that. The area where there's quote unquote a failed Watchman, and one part of that is that not everybody has an appendage that's amenable to this device. With the previous generation technology, there were a higher number of patients who had these little itty bitty appendages that we could not get the device into, or there were issues with size and length, and so that for us was a problem. Another instance of a failed Watchman, if you will, is those patients who come in on the day of the procedure and have now clot in their left atrial appendage for which they did not have clot for when we initially evaluated them, and we have seen that. The third instance is where at the 45-day mark, when we repeat the ultrasound of the heart, the TEE, to assess the patient for adequate closure, and to understand whether there's little minimal flow or no flow going into the appendage, is the other fail point of the device. And what we look at is if there is a leak around the device going into the appendage, so long as the neck of the leak is less than 5 millimeters, that's considered still successful because that will endothelialize. When the leak is greater than 5 millimeters, that's considered also a failure. And luckily, we've only had one patient in the last 5 years with now I think it was a 5.5 millimeter leak.
Amar, I have a question. If we have patients that have real severe bleeding because of different reasons, but I do have a patient that have really been in the hospital, multiple admissions for transfusions, AFib, and they're trying to take care of the source, but the patient continues to go in and out of AFib. What will be the absolute minimum anticoagulation that patient needs so that they can get the Watchman?
No, great question, Dr. Bladwell. I would say that the minimum duration is 5 weeks. Now, if let's say somebody does bleed, in week 3, week 2, we've had that happen to us as well. Obviously, we're a little more concerned about that, but we treat those patients as though they do not have a Watchman device. And if we need to withhold anticoagulation, we do. But if we can get 5 weeks, I feel really good about that.
Okay, thank you.